This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
Our next speaker is Jean-Daniel Chiche, well known to many of us, a haematologist, an intensivist, an anaesthetist before that or in between. He's interested in research of immunity, inflammation, but he's also interested in medical education. A Renaissance man, perhaps, one of many Europeans who come out here and make us feel a little inadequate with their command of language and things, but I'm very interested to see what he's going to tell us and why we shouldn't be down on ICU research.
Thank you very much for this very kind introduction and for this warm welcome. I feel that I'm very fortunate to be speaking between two very articulate speakers. It's what you know, in your life you always need micro nap. So if you need a micro nap, it's now, because what I'm going to tell you is really much easier than what you've heard this morning. But I think it's significantly of significant importance, I would say. So I've been asked to cover this topic. We need to stop ICU clinical research bashing. And I have one disclosure slide. I love science. And that's not going to change. So English is not my first language. So I first had to go and look at what bashing actually means. Harsh, gratuitous, prejudicial attack on a person, group, subject. Bashing literally means hit, assault. And now we learn that it's also used to describe verbal or critical assault. And the topics are now enriched by clinical research. And I think that this is really interesting, because where do we discuss clinical research? We discuss clinical research in our journals, obviously, but we meet at the congresses and speak about our problems. Do we have a problem? So I have to warn you, this happened in Brussels a couple of years ago. It's still happening, I would say, almost every year in Brussels. So that's better with the sound. Is there any way we can get the sound?
Think a little more about the way we create evidence.
So let me go back to this, because it's really an important message.
It is that prospective, randomized, controlled trials are likely to be negative. And we need to think a little more about the way we create evidence in critical care medicine. We had 3 papers in the New England Journal of Medicine, all 3 negative. So this is very complex, but we need to better identify our patient populations and stop doing large randomized controlled trials on so many interventions, because they are all negative, one after the other.
Stop doing large controlled randomized trials. Fortunately, it does not stop people. And I think this is really fortunate. So you can recognize the first author of the paper is not in the room today. The last author of the paper is in the room today, despite the way he likes it. So to be a little more serious, I'd like to tell you that I think that evidence-based medicine and patient-specific, patient-tailored approach, sound physiology, are not mutually exclusive. And they will be used at different time with our understanding of the pathophysiology of the disease process, at different time in the patient history, sometimes in our intensive care. And I think that this is really something that we have to keep in mind. We cannot always practice as if we were engineering our processes. You can wonder whether the purpose of clinical research is to get lots of publication, more grants, lots of money, convert patients into airline tickets. I think that everyone here in the room is convinced that it's to generate evidence that will help us, indeed, treat Alex. This is what we need to do. Alex, you're not that sick, don't worry. So what does it mean? How can we redefine evidence in the intensive care unit? So first, in a lot of cases, we don't have any evidence. And when no clinical evidence is available to guide our decision making, then this is when we have to rely on sound decision-making at the bedside, bring back physiology and common sense at the bedside, and this is the art of medicine. But we also have a moral responsibility. When this type of situations actually occur frequently, we need to study them. And that's when we have to basically bring medicine from art to a science. This is what's fun about research, and this is why we love doing it. But then we should not forget that when evidence exists, we need to systematically deliver care and apply it, and this is what Derek calls the engineering of medicine, and I love this analogy. So first, I'd like to remind everyone that clinical trials, they drive progress and they help us to improve outcomes. And I'm not going to work very hard. This has been published more than 15 years ago. If you reduce tidal volume from 12 to 6 milliliter per kilogram, you reduce mortality. It's in the guidelines. It's what you should do, whatever the severity of the ARDS. And if you do this, these are data coming from the Mayo Clinic. Not only you may reduce mortality, but also you may reduce the incidence of disease that maybe we have been creating along our clinical practice. And the more compliant you are with these guidelines, the more you practice medicine following the evidence when the evidence exists, the better the outcome of your patient and the greater the likelihood of your patient to survive. Another field very close to the heart of my good friend Jean-Louis, transfusion. How many trials do we need so that we finally understand that indeed we may not need to transfuse patients when their hemoglobin level is 8.9 or 9.5? The risk of transfusions do exist, and I would say these are not negative trials, these are positive trials, even when the Kaplan-Meier curve looks like that. These are positive trials that help us treat patients. And I would contend that there's no such thing as a negative trial, provided that the question is relevant, that the study is adequately designed, that it's well conducted, and that we have insightful interpretation of the results, and that indeed it can lead to changes in practice. Because if you actually prove that what the surgeons are doing is irrelevant, they may still keep doing it, unfortunately. That's one example. So I have a dream that we would have true negative trials, false negative trials, true positive trials, and false positive trials. And I'm going to discuss with you false negative trials with one example, early goal-directed therapy. I'm sick about learning that these trials are negative. You all remember these trials published in 2001 where Manny Rivers was saying, maybe you should monitor SCVO2 and based on that give the butamine to patients that have a cardiac output already of 6.5 and give blood even to increase SCVO2. It reduced mortality in this center, monocenter study in the US, from 46.5% to 30.5%. And after this, it's amazing that we jumped on this, one single trial, did put it in the guideline. There were several single-center reports of benefit with decrease in mortality, but with small studies, with historical control, before and after design, and likely publication bias. Fortunately, we have slow adoption of good practice and also sometimes slow adoption of bad practice. And this is mainly because of a lack of a strength of evidence base, logistical burden to initiate the change, knowledge transfer, and mostly about skepticism, because many people were telling, beware, I mean, this is a single US center study, not blinded. I was lucky to be with Derek. He was on sabbatical with us in Paris when those trials were designed, because indeed the community did not entirely believe this. And I would say that the question was indeed relevant. And there have been 3 studies with, I think, quite adequate methodology, adequately designed and well conducted, and you know the result of the studies. No difference whatsoever between usual care and early goal-directed therapy. So the systematic review is also quite clear. For once, you know, when you include studies that are quite homogeneous, I would say significantly homogeneous, you get the result of a meta-analysis that I can believe. You look at the patient, people have said, oh, maybe they are not that sick, and it's not entirely true. Maybe they were treated, the time from emergency department admission to randomization was longer. But at the same time, if you look at the lactate level in the ARISE study or in the PROMISE study, these patients were already reasonably sick and they had high lactate level. What does this mean? It means that none of these studies are a repeat of the reverse trial. They were done like 15 years after. A lot of changes have happened in our community. Patient selection was maybe different. It did mandate a revision of the surviving sepsis campaign guideline, and I can tell you that we are, for now, racking our brain to know what we are going to recommend. The targets for mean arterial pressure and CVP may still be right. And indeed, it all depends on control group mortality, and you've been this morning enlightened about heterogeneity of treatment effect. Usual care has changed dramatically. It's not what it is, what it was in 2001. And fortunately, these studies are not negative because none of these studies undermine the effort that we are doing to promote sepsis awareness, favor early diagnosis and prompt treatment. This does not put any patient into danger. They are not well powered to explore subgroup, but I would say that mandating the monitoring of SCVO2 with protocolized instruction for red blood cells and dobutamine is unjustified, and at least to my eyes, this is evidence, and these are positive trials. Let's move to what you may view as true negative trials, and I'm going to speak about sepsis trials for a minute. You've seen this study. I love Zigris because I've witnessed heterogeneity of treatment effect in patients. And this led basically to withdraw a drug that maybe was potentially helpful to a patient population that we failed to identify. And there was a lot of discussion and debate. Round models of sepsis are bullshit. New biomarkers are needed. We need actually new targets. At the time this was published, most of the targets were already tested and they proved to be not working. And many people started to say the problem is the way we conduct the trials. And if you look at the way we conduct the trials, it's interesting. It's copycat. I mean, you look at 15 years of sepsis trial, and believe me, the inclusion criteria, exclusion criteria, the method section, they can be copy and paste. I reviewed that 2 years ago when I was invited to the NUSA meeting, and I was really puzzled to see that people were extremely conservative despite previous negative results. And sometimes you have the same people in the board of these trials. They have been there forever, still negative trials. We still do the same in terms of inclusion and exclusion criteria. No age limit for patients. I mean, some patients may be dying of, being too old. And we are still looking at sepsis syndrome with heterogeneous infection. Look at the number of urinary tract infection in those trials, and it may vary very well. The percentage of emergency surgical patients also varied from 11 to 54% of these patients. So ICU epidemiology clearly influences the population that you study. Similar inclusion and exclusion criteria do not select homogeneous patient population. And again, we still study syndromes when we should probably be looking at disease. Then there is this whole issue about mortality as a common primary outcome, and our inability to sometimes adequately predict mortality for valid study power calculation. You know this data that's shown that in Australia and New Zealand mortality has decreased steadily over the years. And we don't even know what type of mortality we should be looking at. ICU, 28 days, 90 days, shock-related mortality, all-cause mortality. They are still valid questions, and the answer may be different from one drug to the next. Center selection clearly remains an issue, and if you look at what the results of the study tell you, sometimes they may tell you the true effect of the drug, sometimes they may tell you some type of heterogeneity in the global quality of care in participating ICUs, and there is this whole issue about low volume or low recruiting centers versus high recruiting centers. And there are a lot of proposals to discuss: forget sepsis, move to study disease and use biomarkers, prefer and invent composite outcomes, define quality criteria for center selection, and alternative trial design, but this will be covered by the next speaker. I think we also should accept that RCT may not give you the answer to all questions, and I know that Steve may differ on that, but I'd like to take one example. High frequency oscillation. I mean, that has been used in some select ICUs with some type of success, until these papers actually proved that it was, or at least told us that it was either negative for the patients, or sometimes did not make a difference. I like this study. It showed that it was stopped early because of harm. But if you actually look at what Oscillate and OSCAR actually did, you understand maybe why this did not work. And especially when you're looking at Oscillate, the priority was really given to high pressure in all situations, irrespective of the type of ARDS that the patient had and irrespective of the response to treatment. And there were very poor guidelines to hemodynamics. And maybe sometimes you will not be able to actually prove that a therapy works or does not work, because indeed you need to bring back common sense and physiology at the bedside, 24 hours 7 in all centers, and that may be difficult to do within the context of a clinical trial. It's still evidence. It's evident that you cannot use high-frequency oscillation everywhere for every patient, and I think that from that standpoint, it still should prevent us from bashing clinical research. A few thoughts on things we could do better to finish. Better understanding of the pathophysiology of critical illness, a better approach probably in the discovery of new therapy and in the evaluation of our therapy. We have some problems. There's a lack of appreciation for good descriptive evidence-driven studies upon which biomedical studies should be based. Our scientific infrastructure is mostly based on identification, funding, and managing high-quality science, but not really on understanding its impact. And we need metrics to assess the effectiveness of the distribution of public funding in support of biomedical research. The problem we have is, if you think about the progression of scientific process, it should move from observation to experimentation and then hypothesis testing. But the observation is often the neglected part, and it should be conducted based on skillful analysis performed in human subjects at relevant time points at the site where the pathophysiological process and its treatment effect take place. What I'm trying to tell you here is that maybe we have a lack of sufficient relevance to human disease when we are selecting the hypothesis to be tested at the bench. I love this paper by Mervyn Singer that tells you why what we do in mice may not actually relate to what we do when we are treating patients, and still we very much accept the results of preclinical studies. Indeed, if you want to publish the paper, you cannot publish the clinical study without this consort diagram. Look at basic science studies. I mean, do consort guidelines also apply to animal research? Who withdraw consent for experimental studies, the mice or the men? It's really interesting to know the number of mice that actually enter in a lab and the number of mice that end up on the figures. Either the cat had a good meal or there is something that people are not telling us. And still, when it comes to publish this, we value this very, very differently. I also believe that one of the things we could do better is to strengthen the dialogue we are having with basic scientists. That actually has changed the way we understand cancer. That could change the way we understand sepsis if we were to actually look at biomarkers and mechanism in a different way. Using biomarkers, we have moved to a time where 100 years ago we considered disease of the blood, to a time where we have more than 38 types of leukemia identified and more than 51 types of lymphoma. And you're going to tell me, yes, but sepsis is not cancer. The basic difference is here. You take the word omics and you enter this in PubMed. You choose your favorite omics. And then you cross this with omics and cancer. You still have like 20% of the citations that are valid. And then take your glasses on, because when you do omics and sepsis, you cannot see anything. And if you look at omics and clinical applications, it's always based on cancer. And this is really important if we want to have a better understanding of the human pathophysiology. And if we do not do this, we will never break this vicious cycle of discovery and development. Another word of caution, the issue of industry-driven research. Most clinical trials, they seek to test whether drugs provide sufficient clinical benefits so that it justifies its commercial use through licensing. And the clinical trial design is very often driven by negotiation between investigators, mostly biopharmaceutical companies, and regulatory agencies. Their goal is to identify the most cost-effective approach to achieve licensing and the price they accept to pay. They accept clinical results proving sufficient but often marginal benefit to justify approval or commercial use. And this is really true for cancer research. Unfortunately, there's no incentive to add costly collection so that we understand why it didn't work. And in sepsis, it would have helped us a lot to understand from our failure. Another thing that we could do better is translating research into practice. And indeed, I told you that low tidal volume ventilation saves lives. It's still not happening everywhere in the world. And it may have something to do with funding, education, and translation. And if I had the power to influence decision making, I would say that a grant that does not plan education and bedside translation should not be awarded. Finally, clinical research bashing is counterproductive. When it comes to decide where you're going to put your money, cancer research, diabetes, cardiology, they all speak very highly of their research. The way we speak about our research, if it's negative, it's going to leak in the press. It's going to leak in the main press, and it's going to have a detrimental effect on the money we are being given to do research. Critical care is very important. But if you look at the amount of money that is devoted to clinical research in critical care, it's quite limited. Even with the most conservative approach, we get a very small amount of the grant that are awarded. These data are from the States, but I can tell you that in Europe it's probably even worse. The reasons: limited sources of funding, competitive environment, awareness, marketing and branding. What's intensive care medicine? No one knows. Dead patients will not lobby for intensive care medicine. Survivors may lobby, but for other and very often cancer and cardiology. So I've tried to tell you that we need to be extremely positive about what we do and about these clinical trials because they inform us on the way we should treat our patients. There are always good reasons to wait, not in critical care. Waiting in critical care drives patients to die. Thank you very much for your attention.
I've got one question that's come from the internet. There's a view that that progress in intensive care is due to changes in process of care, that we get better at doing things, patient safety is improved, teamwork, all of those things. What's your view on how we balance that improvement with any imbalance we can get from step change caused by an RCT?
So I believe that these are not mutually exclusive. Indeed, improving processes of care will lead to a better functioning of the ICU teams and probably with better outcome. Actually, processes of care can be also tested by clinical trials. This was one of the questions asked in process, by the way. I believe that they are really not mutually exclusive. And I think that we should think about whether we want to test new drugs in units where these processes of care are already implemented. I mean, if you take the example of dexmedetomidine, if you want to test whether dexmedetomidine makes a difference in terms of duration of mechanical ventilation, and if you do this in a unit where sedation is not prescribed using RAS-targeted algorithm, if you do this in units that have no winning protocols that are effectively implemented and so on, you're going to increase the noise so much then the effect of the drug may actually be lost. So I believe that these are really not mutually exclusive and that the progress may come not only from improving our processes of care, but also improving the drugs we have at our disposal.
The initiatives you undertook during your presidency of ESICM was the Lives campaign to try to raise the public profile of critical care research and critical care's capacity. I don't think there's anything similar in the U.S., and I don't think there's much of anything similar in Australia and New Zealand. What can we learn from that ability, that effort to step out of our scientific space and talk to the public about what we do that's important?
So I think that this is very much work in progress, and I believe that the only way to succeed is really to get international about this. And I would love to see, I would say, Life Priority US and Life Priority Australia with a similar type of action and a similar level of engagement with the lay public. I think it's really very important. Interestingly, when you start to discuss with media agencies or advertisement companies, and they don't know anything about critical care, and when they tell you, oh, okay, tell me a good critical care success story, you start to write your brain and you say, oh, we have the Surviving Sepsis campaign. Look, I mean, we started to speak about sepsis, we've designed the guidelines, and mortality has decreased, we can discuss that, has decreased steadily over the years for sepsis. Great, that's a great success story. What did you do? Oh, now we are giving antibiotics to patients with infection. Yeah, I'm not sure we can actually say that to the lay public. So it's a difficult business, but we need to be extremely first outspoken, positive. I think it's very useful to disclose our data. I mean, the use of data have helped us tremendously to gain momentum at the European Commission, telling them it's unacceptable when you go for elective surgery to face very different chances of survival when you get surgery in Eastern Europe as compared to Germany.
Jeff Shaw from Christchurch. Thank you very much. One of the problems when I reflect on the issues that you're discussing with regard to randomized controlled trials is that everything we do is with what we already have. In other words, if you want to do a randomized controlled trial, it's using the current technologies, the current pumps, the current drugs that we use. Sometimes someone brings in a new drug, but that's often beyond our control. We don't dream these things up. What we lack actually at the moment is the partnership that we need with, say, medical device companies to incrementally improve the technologies to then enable us to investigate new therapies and new treatments. To give you to tell you how bad this problem is, there was a presentation by Jonathan Sakiya about 5 years ago, who's an American entrepreneur. And he told us that that he had this graph that showed the number of applications for new technologies by specialty. Now, oncology, cardiology, orthopedics was right up there with 30 or 40%. Anesthesia was 1%. Intensive care was so bad, there was a little special category for it. It didn't get above the abscissa. Now, something that's fundamentally wrong when we are unable to partner with industry and medical device technologies like everybody else is doing. And that is where I think we're failing. We're actually trying to do things with what we've got. We're not incrementally developing the technologies and methods, etc., to actually improve the chances of an RCT being successful.
Thanks. It's a very valid and insightful comment. I should actually have added that in my talk, telling you that indeed clinical research bashing is counterproductive, because this is the first reason for companies to say, let's stay away from these people. I mean, they basically fight within each other to know whether a drug that seems to be actually working. I mean, put yourself in the shoes of the people of Lilly's, and they've made their mistake, and if they are in this situation today, it's not, I would say, only by, it's not only our fault. But they've invested money. They had a drug that's actually, I mean, ProS was positive. I mean, ProS shock is negative, but ProS was positive, and I believe that a lot of the difference lies in things that Jack has told us this morning. Study still sepsis drugs and come back with this community, and also what's the drive? I mean, people, lay people, the lay public, they are actively lobbying to increase research funding for cancer research. They are not doing it for sepsis because they don't know who we are. So all these issues are actually very much linked together, and I fully concur with your view.
Thanks, Jean-Daniel. One of the points you made was that we aren't very good at identifying the disease, and we tend to recruit on the basis of a syndrome, and the classic ones are sepsis, it's a physiologic, and not a disease-specific definition, ARDS, similarly, and we've got other examples. And that probably is one of the main drivers to Jack's heterogeneity of effect, because we're treating the same treatment with for a whole lot of different kind of diseases. What's the best way of narrowing down the disease and treating the same thing with a treatment, and therefore being able to much more readily demonstrate an effect?
I would say first that we have to go back and study disease. I mean, when 50% of your patient or your septic shock patient have pneumonia, I believe that it should be doable to do a study on patients with septic shock with pneumonia.
But not even pneumonia is the same, is it?
But it really depends upon what you want to do. And if you really want to have a better understanding of the disease, then you may even want to go and look at Streptococcus pneumonia infection, pneumonia in patients with no comorbidities, and this is where you can actually take the power of the technology, the omics technology, to actually learn things. The beauty of the work done by Hector Wong, for instance, is that they are focusing on pediatric patients that usually they don't have liver cirrhosis or not from alcohol, hopefully. They don't have heart failure. I mean, they have different, they are probably more heterogeneous. And even in this patient population, they can identify pathophenotypes and subphenotypes. If we engage very strongly with clinical science, with basic scientists, and speak the same language, and do not think, oh, the technology is there, we just have to put a huge cohort of patients with search criteria, and then with something that will enable you to look at 30,000 genes and proteomics in the bronchoalveolar lavage, where you know that first the number of proteins that actually cross the barrier may change from one patient to the next, and that you just look at the tip of the iceberg. I think if we don't change this, we're never going to make progress.